you see my screen okay? Yeah. Okay, so good morning, good afternoon, and I guess good evening to everyone joining us on Zoom today. And welcome to this ECR webinar hosted by the AHIA Economics of Genomics and Precision Medicine Special Interest Group. So yeah, thank you for everyone joining us in all sorts of different time zones today. Really glad to have you all here. Everyone's probably quite familiar with Zoom meetings and Teams meetings and so on at this point, but before we get started, just a quick reminder to keep your microphone muted during presentations, share any comments or questions in the chat. We'll have about 5 minutes after each presentation and discussion for general question and answer. So put any thoughts, comments, questions in the chat and we'll come back to those. And just to note that this meeting will be recorded. I think the recording's been started and it'll be posted on the IHEA YouTube channel afterwards. So just to give a few quick details about the aim of this webinar series, this is the first time we've tried this, a bit of a new format. So we're aiming to provide a supportive platform for early career researchers to present work in progress. So we're focusing on work that is not published, not completed, to try and maximize the amount of feedback that people can get and use in their work. So things like working papers, draft PhD chapters, analysis plans, anything that isn't completed, polished work. We're not only giving ECRs an opportunity to present their work, but also to get constructive feedback from a senior health economist. So hopefully they can use that to refine their work and move towards their PhD or publications or whatever it may be. And the goal of the webinar is essentially the same as the goal of the Economics of Genomics group. We're trying to create a collaborative network of researchers working at the intersection of health economics, genomics, and precision medicine. So in terms of the webinar format, we've got 2 hours today with presentations from 3 early career researchers. Each ECR will present their work for up to 15 minutes. That'll be followed by a 10-minute discussion by a senior health economist, and then we'll open up for general question and answer, and also allow the early career researcher presenter to respond to some of the discussant comments if they would like to. So yeah, after that brief introduction, we'll move on to our first presentation of the day. Our first ECR presenter is Martin Vu. Martin's a health economist at Health Economics and Policy Research Unit at Queen Mary University London. And today he'll be presenting his work, which is an analysis plan for a cost-effectiveness analysis of clinical metagenomics for pathogen detection in the UK. Martin will have about 15 minutes to present, and then we'll move on to the discussion by Professor Son Nyem from the Centre for Health Services Research at the University of Queensland. So I'll now hand over to Martin to begin screen sharing and begin his presentation whenever he's ready. So over to you, Martin.
Thank you, Michael, for the introduction. And on that note, I'll share my screen. All right. So good morning and good afternoon, everyone. My name is Martin, and it is a pleasure for me to present today at the IHEA Economics Special Interest Group ECR Journal Club. In today's presentation, like Michael introduced, I'm presenting a health economic analysis plan looking into the cost effectiveness of clinical metagenomics for the detection of pathogens in infective endocarditis patients. So very much setting the scene for today's webinar. This is very much work in progress for me. And so I will be presenting, when necessary, presenting concrete results. There will be some results I'll be presenting today, but this is very much a cost effectiveness analysis plan. And throughout the session, I really welcome and ask for input on some specific challenges that I'm currently facing. But just to start off with a bit of background to infective endocarditis. Infective endocarditis is a pretty serious condition that occurs when bacteria or fungi settle on heart valves and causes tissue damage. And in England, there were approximately about 50 cases per million reported between 2018 and 2019. This disease is more common in older patients, but people with prosthetic valves or cardiac devices are also at significantly higher risk of developing the disease. And it is a life-threatening condition. About half of patients who have infective meningitis require some form of early cardiac surgery. 70% of patients die during the hospital stay, and the one-year mortality is about 23%. But managing infective meningitis is a very complex process that requires timely and coordinated care. And when patients with suspected infective meningitis are admitted to the hospital, it's very critical to get that timely and prompt diagnosis. So this usually begins by the patient receiving a blood culture, which is essentially like a blood test or laboratory test to detect the presence of the microorganism that is really causing or a part of their disease. So while at the same time that the patient received the blood culture test, they also begin empirical antibiotic treatment, which is a broad spectrum antibiotic therapy. So sometime later, approximately about 5 days, the results of the blood culture are returned to patients. And patients are categorized into these two broad classifications. So if the blood culture comes out positive, it means that there's a pathogen that was found in the blood culture. So it could be a staphylococcus infection or a streptococci infection and so on. Or there can be blood culture negative, where no pathogen is identified in the blood cultures, but they still have that clinical evidence to suggest that they have the disease. So once they receive the results of the blood culture, there is a change in treatment. For most patients, there will be a change in treatment, particularly if they're in that blood culture positive group. And that treatment changes depending on the bacteria or the fungi that is in the blood. For a subset of patients, they will also require additional cardiac surgery, and there are a few different indications of why they may require surgery, such as whether they have heart failure, an uncontrolled infection, or at risk of developing an embolic event. Um, so once they amend the treatment, the course of treatment is usually about 4 to 6 weeks, and most patients are in the hospital through that duration of the treatment. So it's a very lengthy hospital stay before patients get discharged. But there are some limitations in blood culture. Particularly 17% of patients are in that category of the blood culture negative infective meningitis, where no organism is grown from the blood culture. And also, blood culture results can take up to quite some time to be returned, 5 days as previously mentioned. And so as a result, patients are often treated with more toxic and less effective antibiotics, increasing their risk of complications and mortality. On the flip side, clinical metagenomics offers a transformative approach to infection diagnosis. Unlike blood cultures, clinical metagenomics analyzes pathogen DNA directly from the clinical samples. And there are two main limitations of the blood cultures that it overcomes. First, you can get the results within 6 hours, and it offers a broad pathogen detection as well. The technology itself uses sequencing platforms such as Ion Torrent, Illumina, or Oxford nanopore technologies. And clinical metagenomics has shown promise in identifying both bacterial and viral pathogens in studies of urinary tract infections or pneumonia. Currently, the AIMIT IP-IE trial is currently underway, which is a prospective controlled diagnostic study comparing clinical metagenomics with blood cultures in diagnosing infective meningitis. And essentially, studies help evaluate its accuracy and real-world clinical impact. So we hypothesize that the use of clinical metagenomics allows for earlier and more accurate detection of the disease, and by sorry. And by identifying the causative organism more quickly, clinical teams can initiate more appropriate and effective antibiotics sooner, and this in turn reduces the need for surgical interventions, lower the number of patients who die within hospital, and ultimately lead to better outcomes for those affected. And so there's currently no cost-effectiveness study on clinical metagenomics for infective hepatitis. And so to address this gap, we'll be conducting a cost-effective analysis comparing clinical metagenomics with conventional blood culture, specifically for diagnosing infective hepatitis from the perspective of the UK National Health Service. So to introduce the model that we are planning to implement, this will be a two-part decision tree and discrete event model. So the decision tree starts off with the patients with suspected infective hepatitis, splitting them between the two strategies of clinical metagenomics or blood culture. Depending on the arm, patients can then be categorized as a blood culture positive or blood culture negative. And as mentioned before, a subset of patients will require cardiac surgery. And at the end of their hospital stay, they can, at the point they can survive or experience death in the hospital. Patients then transition to the second part of the model, where they can either start on the well state and stay in the well state, or transition to either stroke, congestive heart failure, or death. So in our model, we do not consider pathogen level or treatment specific groups. And this is good because there's such a large number of possible pathogens that we could model, but given the limited data availability, we could categorize it into the blood culture positive and blood culture negative groups. And considering a 5-year and a lifetime horizon to two time horizons, applying a 3.5% discount rate on cost and outcomes. So with our model, starting off with the parameters and the data that will inform the parameters for the comparator arm, we'll be first using a registry data called the BART Endocarditis Research Registry to first estimate the proportion of patients with blood culture positive versus blood culture negative, and then perform separate logistic regression models to predict cardiac surgery and death at discharge. So this is a prospective observational registry located with recruitment within Bart's National Health Service Trust, and there are about 730 participants in the registry after data cleaning. And so in the data, so this is some demographic statistics of the research data. So about 13% have blood culture negative compared to 87% blood culture positive, which is a slightly higher blood culture positive than reported in literature, and about 50-50 split almost on the proportion of patients who require cardiac surgery. Those who have blood culture positive tend to be a bit older, more males, and previous history of reproductive cancers remains the same. Similarly with whether they had a prosthetic valve and congestive heart failure at admission as well. Logistic regression results indicate that male patients had higher odds of undergoing cardiac surgery. In contrast, older age and the presence of prosthetic valve were associated with lower odds of surgery, and patients with blood culture positive showed increased odds of surgery, although this was not statistically significant. And that's similar to as well with the congestive heart failure variable. Turning to in-hospital death, increasing age was associated with higher odds, while having cardiac surgery was linked to lower odds, and other factors such as male gender, blood culture positive, prosthetic valve, and congestive heart failure admission, and embolism during admission showed higher odds in hospital death, but did not reach that statistical significance. We will also be using the UK Biobank to perform separate cost regression models to predict long-term outcomes. which is a prospective cohort of about 500,000 UK participants with recruitment all around UK. And after data cleaning, there's a cohort of about 360 patients with infective endocarditis. Shown here are the Kaplan-Meier curves illustrating the key outcomes that we wish to model in this disease, including mortality, congestive heart failure, and stroke. The first plot indicates that approximately 76% of patients survive beyond the first 5 years. Heart failure develops in nearly 20% of patients within 2 years, as shown in the second plot. And as for stroke incidence is lower, but still notable, with about 3% of patients experiencing a stroke event during the follow-up within the UK Biobank data. And our cost regression analysis examined the impact of age, gender, and surgery on all three outcomes. And in all three models, none of these covariates that we included in the model showed statistically significant association with either outcome. And so for the intervention arm, currently, as I mentioned, the clinical trial is underway, so we don't have that clinical data yet. And so we are thinking about using expert input to estimate the portion of patients to be classified into the two groups using clinical metagenomics. And we're considering this a conservative approach and assume that surgical and in-hospital mortality rates are the same in the blood culture strategy. But we say this is a conservative approach because we're still thinking about how does clinical metagenomics affect how to propagate a treatment effect with clinical metagenomics, particularly on surgical and in-hospital mortality. Nearly wrapping up, in our costs and utility, for the costs, we'll also be using the UK Biobank, which includes administrative hospital episode statistics data, and we'll be performing separate generalized linear model to estimate the cost of the different states. And these are the utilities for the different states for well, stroke, and congestive heart failure based from literature sources. We will be conducting one-way sensitivity analysis, and the main parameter here being the proportion of patients assigned to the two groups from clinical metagenomics, as well as probabilistic analysis. So just to wrap up, in this analysis, we looked at, in this presentation, I should say, we looked at into an analysis plan of an early cost effectiveness of clinical metagenomics compared to blood cultures in patients. And the goal is whether to assess whether faster and broader pathogen detection could lead to better outcomes and more efficient use of resources. Our model will capture both the immediate and long-term clinical outcomes of the disease. And the key challenge that we're experiencing with our analysis is that limited clinical data and how to think about propagating that treatment effect. Future work will include updating that cost-effective analysis with the trial data, but we're not anticipating that trial data to come anytime soon. So I'll end there, and I welcome again any input specifically about the intervention as discussed. And I just want to acknowledge my collaborators on this particular project. Thank you for listening.
Great. Thank you very much, Martin, for the first presentation of the day. That was really interesting. Thank you. We'll now move on to Professor Son Nyem, who will give around 10 minutes discussion of Martin's presentation, and then we'll open up for some questions, answers, or responses from Martin afterwards. So over to you, Son. Thank you.
Thanks, Michael. Thank you, Martin. Let me share my screen. Here we go. Everyone see my screen now? Oh, thanks,
Yeah.
Martin, for the presentation of the excellent, ongoing study. Yeah, through the presentation, I understand it more than you just sent me the slide before. So overall, it is a very important topic of study. The condition is having severe consequences with high probability of having surgery or death in hospital, and also the intervention patterns genomic is trending is important, and you could have a wide effects on the health services. So having concrete evidence on the value for money of the intervention is important, and you are contributing to that. You are combining both the trial data with the real world data. So it's based on a solid combination of the registry and the biobank with the protocol of the trial you already designed. And you already start the analysis and have an initial result presented today, so it's a good thing. However, I do have some questions, mainly for the clarification. So first of all, the choice of the two-part model was not explained too well. So don't know why this two-part model was selected, and why not the other option. So the reason three-part, I understand, is the intervention CMG and the comparator with the traditional blood test. The second, look like it's the this Markov model to me. It's demonstrate the transition between the different health state. Doesn't look too much like a discrete event, whereas the patient flow would be indicated whether they meet the admit to the hospital first, having either blood test or CMC, and then go through a bunch of treatment and then discharge. That's the flow we expect in a discrete event, but the diagram doesn't show like that. And you later on mentioned briefly that you use a generalized linear model to estimate the cost difference between health states. So I'm not too sure how it would be done, and why the other option, obvious one, is the bottom-up approach, where you have the trial design already, you have a clinical guideline of how much resource could be used to treat if the patient go through a certain health state, for example, surgery. So how much resource would be used, for example, doctor, nurses, and other materials consumed. It should be in the clinical guideline somewhere, and you quantify those resources and the unit cost. You will have a cost of treating on the average cost of treating different state. If the guideline is not clear or the data is not there, you can even consult the literature or the database of the patient with those health state. So, and also it's not clear what kind of cost data you already have. What are the cost item? So if you already have it, make it clear. If not, at least mention the source where you would get the cost data and what state you are in terms of gaining access to those data. And yeah, again, I misunderstand whether or not you are trying to do the Markov model or not. If so, if you do a Markov model, so what are the steps in going to estimate the transition probability between the health state you mentioned in the diagram? And not only until today, I know that why you don't use the trial, because in the protocol there is mentioned the sample size is quite sizable, 200 patients, and I wonder why they're not using it. But now I know that the data is not there. So why is the decision to use those observed data, registry and biobank? If the other option, for example, you go to literature and you see what is the effect to the health outcome of interest and what is the incremental cost that the literature, especially in the country with the similar context to the UK, have found. If you found nothing, then you can go to the expert opinion or the data from the real world registry data. But have you tried the other? It's easier option like finding from the literature or expert opinion. One of the key thing in the CMG is increase the accuracy and the faster turnaround time. So it's not mentioned that how you are going to use to estimate the effect in these two regard. So from the presentation, I see that roughly the effect in terms of the turnaround time is 4.5 days, right? So traditional method, you need 5 days for the blood test to go through. And the new method, you have 6 hours. So at least you save 4.5 days of patients. While they do blood tests, they stay in hospital, right? So at least everything else is the same. Hospital length of stay when reduced by 4.5 days, and hence the cost and maybe health outcome would change from those as a result. But at least you need to mention at least the expected change in the turnaround time. And the accuracy, if I understand correctly, the traditional blood test, you have 18% negative. Will the CMG overcome this or not? Because in the DNG, I still see the probability of having both positive and negative in the CMG arm as well. So not sure what is the effect in terms of improved accuracy of the CMG compared with the traditional methods, and how this improve in changing the accuracy when results in the flow-on outcome of interest. And there are a bunch of outcome of interest, for example, fertility in hospital surgery and so on. But the main focus is on the quality of life, right? So are you going to plan to investigate the other outcome as well? So overall, it is a very good study ongoing, but already provide a lot of information that it will be a promising study based on the limited amount of time and information from those slides. That is my brief comment, and yeah, looking forward to see the the study complete and published in the peer reviews journal. Thank you.
Great. Thank you very much, Son, for the discussion of Martin's presentation. And thanks both Martin and Son for that. That was really interesting to hear. I'll hand over to Martin again just quickly if there's anything you'd like to say in response to any of Professor Nguyen's comments. And we'll keep an eye on the chat while you're doing that in case there's any other questions for general Q&A. But yeah, over to you, Martin. Anything you'd like to say to respond?
Yeah, well, first of all, I just want to say thank you to Sun for reviewing our work and acknowledging the strengths and allowing me to clarify a few things about some of the decisions we made with our analysis. So I think the first point with regards to the choice of the model, so as mentioned, we've been using a two-part model, first with a decision tree and then a discrete event model. And so I think we have two data sets that we're currently working with, well, three data sets, but focus for now is the two data sets, particularly with the registry data and the UK Biobank. And so I think that the registry data, and given that where the data comes from at the Barts NIH Trust, which is a very clinically specialized site for the treatment of infected endocarditis. And so I think that that data provides a wealth of information about the experiences of patients, particularly around whether they receive cardiac surgery and all the different complications from the disease and the treatments as well. With the UK Biobank data, that will form the more long-term outcomes. And I think that the advantage of working with that particular data is that it is the patients who are enrolled into the UK Biobank, they have their administrative hospital epistatistics data linked. So in doing so, we have diagnosis dates and death dates as well from that particular data. So I think, and given the size of the cohort that we found with infected endocarditis, we thought that might be worthwhile to explore and measure and estimate the parameters around the time to event of different states or different events for the patient of interest. I think if we were experiencing some challenges when we actually come to the computational and implementation of the model, we will revert back to the Markov model. I think that's more of a contingency plan for us. And we did look into literature around clinical metagenomics, and while there is some evidence for other diseases, this AIMnet IPIH trial is really one of the first for clinical metagenomics in this particular disease. And so, I guess, as I mentioned, the data is not going to come until quite some time. So, but I think there's still value to understand where the early cost effectiveness indicators where it might be. But I think another issue that we're experiencing is that, yes, we probably can, as a first point, use the expert input to understand how much better our intervention arm or clinical metagenomics can categorize patients into the positive and negative groups. But the one thing that we're struggling to think about is that faster turnaround time. So the clinical genomics will provide diagnosis within 6 hours. And so one could argue that in doing so, in that particular group, because you have that faster diagnosis, less or fewer patients requiring cardiac surgery because you're providing the right treatment earlier, and therefore reducing their in-hospital mortality. But the way that we're going about it currently is that we're assuming that the proportion of patients with cardiac surgery and in-hospital mortality is the same in either groups, but we suspect that there might be a improved benefit from that faster turnaround time. But we're not so sure how to incorporate that in the analysis, or what's be worthwhile to present, or what sort of analysis to perform to capture that particular value. As for the cost data, so because we're using the UK Biobank, and for the hospital statistics, there is also the healthcare resource group variable linked to each patient record as well, which contains cost of their stay. And so in our particular generalized linear model, we will be essentially assessing the cost of a patient in the well state, stroke or congestive heart failure, but also accounting for the years that they are in that particular state as well. And yeah, just to emphasize that the outcome is quality just of life years, and we're putting this into assessing the costs and incremental cost effectiveness between the two groups. I think those are the main things I'd like to clarify. I will also take any questions if there are questions for me.
Great. Thank you, Martin. So I don't see any questions in the chat at the moment. Or anyone on the call, if you want to put any questions in the chat, we're happy to take them during the Q&A session. I've got a couple of questions about the presentation and discussion, actually. So just firstly, on your time horizon, I noticed you've got two time horizons for the model, a 5-year and lifetime horizon. But then looking at your Kaplan-Meier diagrams, it seems like most people survive beyond 5 years. So I'm just wondering which time horizon is your base case analysis? Is it the 5-year or the lifetime?
Yeah, I think our original protocol states 5 years, but that's something that I can definitely take away with the collaborators on this as well. And I think one of the motivations again is just we're uncertain about that intervention arm.
Yep.
And so I think that's why we chose 5 years as the base case. But I take your note about especially with those Kaplan-Meier, so like there was like 12 years of follow-up data for the current standard of care group. Yeah.
Yep. Yep. And then secondly, you're obviously bringing together quite a lot of data here, but being genetics and genomics and the area, there's obviously some areas where there's a lack of data.
Yeah.
And I'm wondering if you've considered doing any value of information or EVPI work alongside this to see where it might be worthwhile getting some more data.
I'm very open to a VOI on this,
Yep.
especially if we're performing the analysis with the current data that we have. And yeah, like because the trial is recruiting and it's going to be 12-month follow-up and longer term follow-up in that trial data. It's not until quite some time to get that trial data, and I think that'll be really worthwhile. But I think in the meantime, yeah, I'm very much open to a VOI on
Okay.
this as well. Yeah.
Great. Yeah, I was thinking VOI is emphasized quite a lot in health economics courses, but very rarely see it anywhere. But this seems like a really, really good area for it, given some of the lack of data on specific pathogens. So yeah,
Yeah.
great. Well, thanks very much again to Martin and Professor Nyem for their presentation and discussion. That was really interesting to hear about. Hopefully that feedback was useful for you, Martin, and thanks again to Son Nyem for preparing his discussion. So we will move on to our second presentation of the day. I'd now like to introduce Francisco Santos Gonzalez. Francisco is a PhD candidate at the University of Melbourne School of Population and Global Health, and today he'll present his work on the economic value of functional genomic diagnostics for rare disease patients. So 15 minutes for Francisco to present, and then Francisco's work will be discussed by Professor Martin Downes from the Griffith University Centre for Applied Health Economics. So Francisco, over to you whenever you're ready to start sharing your screen. Thank you. And if anyone has any questions, please feel free to put them in the chat. We'll come back to them at the end of the discussion. Thanks.
Thanks, Michael. I'll just share my screen now. Can you let me know if that's sharing now? Perfect. Well, good afternoon for all of us in Australia. Good morning for the people in UK. Yeah, my name is Francisco, and I am a final year PhD student here at the Economics of Genomics and Precision Medicine unit at the Melbourne School of Population and Global Health. And today I will present a little bit of the research that I've been doing as part of my PhD. So this is a good opportunity for me to communicate the findings that I've had so far. And there's also an economic evaluation that's still ongoing. So I would really value any feedback for that one. So to start, I'll just briefly talk about rare diseases. So these are conditions that affect less than 1 in 2,000 people. And the majority of them are caused by genetic variations. And to date, there have been about 7,000 rare diseases reported. Even though they individually they only affect very little people, globally, more than 3 million people are affected by rare diseases. And this includes conditions like mitochondrial diseases or inherited cardiac disorders. Now, traditionally, since they have a genetic origin, approaches like panel tests or microarrays have been used to try to diagnose them. But they are not great because they only look at a subset or specific genes where disease usually happens. And I like to think of that as the early ChatGPT. If you remember a few years ago when it was first released, this language model only had access to information before 2021. And then if you wanted to look for more current information, there was a limitation, and you couldn't access that. And that's a little bit similar of what happens with these traditional approaches. You can only look at a subset of a specific information, but if the information that you are looking for is outside of that, you will have a low chance of success. And that's caused what we call a diagnostic odyssey. So people with rare conditions go through investigation after investigation for usually a number of years. But that's been changed with the use of genome sequencing, so like genome and exome sequencing, which are faster and less intensive than these traditional approaches. And they have demonstrated an improvement in the diagnostic rates of rare diseases. And that's because they now have access to all of the information in the genome. So I'm pretty sure you all remember when ChatGPT was given access to the internet. We didn't have that limit of information before 2021. Now we could see current information, and that really improved the way that that we can use these tools. And in the case of rare diseases, having access to all of the genetic material really improve the diagnostic capabilities, and the ability to make to find these genetic variations. Now, even though that's been great, these sequencing approaches only look at the information in the genome, and sometimes the genetic variations that cause rare diseases actually affect the information that's not present in the genome. So they would affect the end products of gene expression, which are proteins and RNA. And because of this, we actually need complementary approaches that that go beyond DNA. And those are functional genomics, so approaches like proteomics, which study proteins, or transcriptomics, which study RNA and related processes. And by using these approaches, there is a better chance of finding the causes for those diseases where DNA sequencing information is not sufficient to establish a diagnosis. So then, the use of functional genomics can improve the diagnosis of rare diseases, and so they might help us address the healthcare and economic challenges that are associated with all of those patients that haven't been able to be diagnosed with a rare disease with current approaches. But to do this, I'm also addressing other challenges that we found in the way that we generate health economics data for genomic testing. And one of those are the lack of detailed cost estimates of genomics. And this is a big issue because inaccurate cost estimates can misinform decisions about the investments needed to implement these technologies. And also the information that's been generated to date is difficult to compare across technologies and across different countries. And there needs to be a better approach in the way that this information is generated. Also, preference data has been gaining in importance in economic evaluation, because preferences, social considerations, and clinical factors can influence the cost effectiveness and health budget impact of genomic technologies, with no information specific for functional genomics exists to date. So that's one of the things that I looked at. And I also I'm also in the process of undertaking an economic evaluation and see how the use of functional genomics compares to reanalysis of sequencing data after 18 months, which is one of the emerging approaches to try to diagnose those patients where the initial genomic testing or the initial genomic sequencing didn't lead to a diagnosis. And the evidence that I have generated to date, it goes across several studies, And the first study that I did was to address that need for detailed cost estimates. And we knew that using microcosting approaches, we can get more detail in those cost estimates of genomic testing. But we really wanted to find out more about how these studies are made. So we undertook a systematic review of microcosting studies of genomic sequencing. And we actually found that these studies, the estimates that they have generated vary significantly, from a few $100 up to almost $9,000. And that was a little bit disappointing because if by using these approaches we hope to obtain better data, maybe there are a few things that need to be done so that we can actually do that in a better way. So in the following study, we try to see how we can improve the way that these microcostings are made, and generate better data, and which can be used to estimate the costs of other genomic technologies, such as functional genomics in this case. And I think that I messed up my transitions, but anyway. So after that first systematic review, I then went to do a microcosting study of functional genomics. And here I really wanted to see, how we can develop a study where we include all of the equipment, consumables, and people that are needed to do these studies, and also improve the way that we report the sources of data, the sources of costs, and also do some sensitivity analysis to see the fluctuations in all of these inputs. And well, what we found from here was that proteomics costs around $600. The majority of these costs come from labor, but the main output of this study was to really demonstrate that, by being really clear about the sources of costs and inputs that we're using, and all of the considerations that that we included in the microcosting model, we can generate data that's more generalizable and and can be used in other settings. After that, I moved to value the benefits of functional genomics testing, and that is because one of the challenges in the economic evaluation of genomic testing is that a diagnosis might not always lead to outcomes that are traditionally valued in health economics, such as changes in treatment or an increase in quality adjusted life years. And by doing this contingent evaluation, I was able to estimate a willingness to pay of around $1,500 US. And this shows that individuals and families with rare diseases really value obtaining diagnostic information. And also, since there is no established threshold, for the cost effectiveness of additional diagnosis, this information can be used in a cost-benefit analysis, so that we can actually estimate those added benefits, which are not which cannot be valued through metrics like QUALYS. So I am using all of these these costs that I have estimated before, and this willingness to pay, in an economic evaluation of functional genomics testing, where I'm using a decision tree model, and I'm estimating the cost effectiveness and cost benefit of functional genomics testing. And just briefly, I'm using a decision tree model with a 18 months time horizon. And what we're evaluating here is what is the added value of using functional genomics testing for patients that that have a candidate gene from my previous genome sequencing, and see if there is any value in using functional genomics, or to just wait 18 months and have reanalysis, which is so far the best way of reanalyzing data. And we're estimating how many more diagnoses can we get using these approaches, but some of those will also be made just from reanalysis from that updated information that's generated after the initial tests. And one of the limitations that I'm facing here is that I am only considering costs from the tests, and that's because since these diagnoses are made in a research setting, it's difficult to estimate costs associated with changes in clinical management. And well, the outcomes that I'm going to estimate from this are the number of additional diagnoses, estimate the cost of additional diagnoses, and I will also do that cost benefit analysis using the willingness to pay from my previous study. And I also intend to use that willingness to pay to establish a decision threshold, so that I can value those additional diagnoses and see if they will be cost effective from that perspective. Yeah, I think that I've run out of time. So I just quickly want to acknowledge my supervisors and the amazing people that I worked with during my PhD. And yeah, that's it for me. Thank you.
Thanks very much, Francisco, for your presentation. We'll now hand over to Martin Downs for the discussion of Francisco's presentation. And again, just feel free to put any questions in the chat. We'll come back to them after Martin's discussion. Thank you.
Thanks, Michael. Good morning, good evening, good afternoon, wherever people are. Great on an international scene. Let me see if I can try and get my thing shared. Let's see. Okay. I always get a bit nervous when people call me a senior health economist. I'm definitely senior in age, but I'm not sure about senior health economist, but I'll give my best shot. Thank you for a great presentation, Francisco. It kind of like what San was saying, actually, a lot of it makes a little bit more sense, having heard the commentary behind. I must admit, I was trying to figure out how ChatGPT fitted into the introduction, but it makes a lot more sense now. I just have a few comments, I guess, and maybe a few questions that you can answer. It's definitely an interesting and difficult space, and it's great to be undertaking something quite difficult to do. So fair play to you for doing that. I guess one of the interesting things, and you were talking about sequencing and things there, so because I've done a little bit of work on the kind of whole genome sequencing, exome sequencing, and I guess it's as you say, a fast-paced, moving area, and I suppose sometimes the comparators aren't even really fully examined in that kind of cost effectiveness cell technology assessment space. So I suppose it's considering what you're going to use as your comparators and ensuring, I guess, that's what's going to happen, or that is kind of what's happening at this moment in time. You do raise the challenges of microcosting, and I had a look at your systematic review, and it's very interesting. When I saw the comment, I thought, oh, I wonder, is it a time number of genes they were looking at, but it doesn't seem to have any rhyme or reason as to why the range is so large. So obviously it does cause and raises some questions for you yourself when you're trying to put this together. And I think the other thing as well, of course, is how do we future-proof that value and the cost of doing all these different the different things, because obviously, well, hopefully as the technology gets better, it should get cheaper. But of course, what often happens is it gets replaced by better and more expensive technology, so it doesn't always come down in price. Having a microcosting framework is a great idea, but I find, you know, if you've set it up at the start, at least when you're revisiting, you can have a look at how that changes. But whether it actually really gives you what is happening in that space properly is quite an interesting one. I'll talk a little bit about that in a second. The willingness to pay by the patient is always a very interesting aspect to this space. And I suppose it was interesting to see the $1,500 mark, because some of the projects I've worked at, the whole genome sequencing doesn't necessarily come under that price tag. And I suppose I was kind of, when I was looking at it, I was considering perhaps the kind of commercial viability, and how when we say, you know, patients are willing to pay this amount of money for something, but if it's actually not commercially viable to produce something at that rate, then how do we approach that, and how do we move forward in that space? So there has been a couple of examples of you know, genetic companies, you know, going to the wall because they're not charging enough, or restructuring their business because it's such a difficult space to really set I guess a price for some of the products that are out there. So I suppose it's something to consider maybe when you're looking at that cost and how you're going to create that cost, and using, I guess, the willingness to pay threshold from the patient's perspective is a very interesting approach. But I guess, can we get something over the line if, you know, if the company isn't able to produce it at a rate that the patient or the government is able to or willing to pay for it? So and I guess that other thing is that, you know, the patient pays or the government pays. So how do we marry that up in that space of willingness to pay from a cost effectiveness perspective? The use of Australian court, I don't know what your Australian court is like. I often worry sometimes about the quality of data. I've done some work where, you know, you've got really good, perhaps clinical data, but the actual costing data is poor, or, you know, the service and data is really good. So you got, you know, the hospital health services data that's really good, but then the clinical data doesn't marry up that, and try to cost all of those kind of estimates can be tricky. So I suppose interested to know what kind of quality of data you have from this cohort, and I suppose how that fits in with your comparators. I think, yes, I've got another few notes on that, things to consider. The test costs, I thought microcrossing, good idea. Using the willingness to pay as a for your cost effectiveness analysis is good, but I definitely think you need a discussion around how you know, that willingness to pay fits in with the actual commercial cost of one. The microcosting tends to look at just the cost of doing it, and then the commercial side of it is the add-on. Like, what do companies need to add on to make money from this? And I've seen it because I do quite a bit of the MSAC work, and I see a lot of, you know, the MSAC, or it usually happens at kind of the S committee stage, where, or even the PAS committee stage, where you know, they look for justification, and they look for things like microcosting, but you don't see that in PBAC. You don't see, you know, the S committee from the pharmaceutical perspective looking for that microcosting or any of those kind of things. They just you know, of course, they've got a bit of wiggle room for negotiation and stuff, but that's kind of, it's an interesting part, I guess, that if we have these new and awesome ways of analyzing and diagnosis, how do we then put a price on it that is commercially viable, if we're just using a microcosting, which only covers the cost of doing something? So I think it's an interesting space that still hasn't quite been teased out. I don't know. I don't think at this point, but, you know, it's something to bear in mind, I guess, when you're trying to put together those costs. And I think using cohort data, we often look at the cost of doing the test and what happens afterwards. And we kind of forget what happens before, especially if we're looking at using a kind of pre-implementation cohort. Often we tend to look at the kind of whole of the comparator before we implement, but often we only look at what happens after they get the test. So I guess bearing that in mind, you know, the actual test is part of a journey for these patients. So they're not going to get it straight away. So you have to make sure, I guess, that the cost that you're, you know, if you've got that cost data from the cohort, that you're using the whole cohort cost that covers their journey in both the comparator and the intervention site, because you can overinflate, I guess, the benefit from the intervention side if you're just measuring after they've been tested, because that is part of their journey. And I think around that clinical utility, the change in management, does it mean better care? But that can also mean more expensive care. So you've also got that additional cost of that change in management to consider when you're putting it into play. And you may have already got that on your mind, but I guess these were things that came up when I was reading what you put forward. Number of diagnosis, it's always one that we use. It often is difficult to know what that means in the kind of cost per quality space. And some people try and, you know, perhaps put a quality range of what a diagnosis means to a patient, or to the service, the system. So it might, you know, thinking of, I guess, it's not hard and fast in the Australian aspect, but it's still very much, you know, the problems, the cost per quality is still very much forefront of decision making. It doesn't always happen, and the committees look at it differently depending on what our intervention is, and probably in this space they probably would look at cost per diagnosis, but I think it's something to bear in mind as to whether, you know, you can pull those problems in, if there's any aspect of the cohort that allows that, because I know sometimes the hospital data, they do collect problems. I know some of the hospitals up here in Brisbane certainly do. Yeah, again, I was thinking, kind of trying to think a little bit around the commercialization, and perhaps, you know, you got your incremental net benefit, but I'm just wondering whether, like, a net predictive value, if you're thinking of investment, future developments in that space, whether that's something you could think. It may not fit into what you're trying to do here at the last stage of your PhD, but it's something that maybe we should be thinking about, I think, in this space where we're creating new ideas and investing into new technologies. As you say, a lot of it happens in the research space, and that moving from research to commercialization and in genetics seems to be a tricky path. So I wonder whether something like that, maybe thinking into the future, perhaps not for this particular project yourself. Yeah, the other thing I have, I ran short in my sentence for some reason, but, you know, thinking about the clinical input, what on the kind of change in management, because sometimes it's not clear from just the cohort what's happened, because you may not necessarily, and I don't know whether you have that clinician data coming in as to whether they did change management because of the test they got, because sometimes it doesn't actually lead to change, it just leads to more knowledge, and your knowledge is good, of course, but I guess it's trying to understand whether the intervention itself has led to a clinician making a change in management, and perhaps maybe in certain cases you might need that clinical input if you have the time and space to do it. Yeah, I was thinking about the decision threshold as well, like that willingness to pay for the patient, but I guess from the payer's perspective, you know, if we're just looking at what if a patient is going to pay, do we then end up with that kind of equity issue of not everybody's going to be able to pay that much money, and I can't remember what I was going to estimate. Yeah, so you got your average willingness to pay, but yeah, so I guess we have to think, you know, on the threshold side of things, whether because we know in rare diseases, governments tend to be a little bit flexible on that willingness to pay. So I guess thinking about how that would fit into your cost effectiveness, because you're kind of already starting with a willingness to pay threshold from the patient's perspective in the cost side of things. So I wonder how do you deal with that in the far end when you have a cost per diagnosis, and how you would treat that, I guess, in your discussion. Yeah, those are really just the kind of comments and thoughts I had. So I hope it's helpful. If you need more help later on when you're pulling it together, I'm happy to have a conversation about it with you.
Thanks so much, Martin. That is really, really helpful. I guess, like, yeah, I just have two quick comments. On the feasibility of microcosting, having done one myself, it takes a lot of time, it's a lot of effort, lots of inputs. But the good thing about it is that you kind of like the way that we approach it was like an ingredients-based approach. So like, imagine that I want to make a pizza. I think about the ingredients that I need, the equipment, and then the people that I will use. And then when there are changes to that recipe in the future, instead of redoing the whole analysis, I can just focus on like, okay, now I'm buying the sausages from this store, or I'm using gluten-free flour instead. And in I guess in genomic testing, though the changes that might come in the future are like automation or of data analysis, or maybe new sequencing platforms. And we build a microcosting in a way that we can just change that one thing and then predict what any cost will be. We made a commentary on talking about the disparity in Australia between the expected costs of genomic testing and what the government is reimbursing now. And we believe that they're actually reimbursing at a much lower level than what it actually costs to do these tests. That might be creating those access issues, because labs are not able to offer the tests at that like lower cost, and that might create those issues that you're talking about there. In terms of quality of the data, that's coming through from a research project from the Murdoch Research Institute. There's actually a lot of data gaps so far, so I can't really comment on like the quality of that. But you gave me like a really good sense of what I have to look for, and how to engage with clinicians to get these additional things. So thanks so much for that.
That's
Yeah, and yeah, and I see a couple of questions in the chat about the difference in costs. Is geographic location a factor? What we found to be the biggest factors were things as what sequencing kits were used, the salary scales of people, or like what samples were used, if you needed saliva or like blood or tumor tissue. Vanessa, if you're interested, I can provide a link to the systematic review. And we were actually surprised with these findings. We thought it would be different things that would influence cost, but it was actually like the fine details. And there's another question about outcomes and valuing caregiver outcomes. No, I don't think we're considering those ones so far, but I think it will be worth checking if utility data is available for that, because that will be good.
Great, thank you. And I think there's one other question there from Sally in the chat. There's given that MSAC prefers evidence from cost utility analysis rather than cost benefit analysis, did you consider collecting any utility data in your study as well?
I think there was some utility data collected, but I'm not sure if it was collected for all participants and if it reflects the change from before being enrolled in the study and after. But yeah, that's something that thanks for highlighting. Like that's actually like what MSAC is expecting to see. So yeah, I really have to think about that.
Thanks very much,
I think
Francis.
I'll just make a comment. I think with MSAC in this scenario, because it's rare diseases, it's very difficult to collect utility data from patients with rare diseases, and the numbers of getting them is quite low. So again, I think while it's optimum, it's probably not the end of the world in that kind of whole process, because they will consider those kind of aspects of the disease and space that you're working in.
Yeah, it seems like this is another area of genomic testing where we're basically using cost effectiveness, cost utility, and cost benefit analysis and seeing what happens. And there's always a challenge in communicating to policymakers which approach should we actually use. So I wonder, Francisco, have you got any thoughts on communicating these results to policymakers and using the results of your PhD work to inform policy? How do we explain that there's 3 different numbers depending on which approach you use to policymakers?
Well, that's a hard question. I think that the approach that I would take would be, highlighting what the additional number of diagnoses is and what that means to patients, and talk about how it is difficult to measure these outcomes in those like more established ways, and use that supportive evidence from a cost effectiveness analysis to try to show the value. But yeah, it's something that I haven't really thought about yet.
Sorry for the difficult question. It's a question I couldn't answer in my PhD either, so don't worry. Yeah. So yeah, thanks very much, Francisco, for your presentation, and Martin for your discussion. That was really interesting to hear. So we will move on to our final presentation of the day now. I'd like to introduce Amber Salisbury. Amber's a research fellow at the Health Economics in Health Economics at the University of Manchester, and today she'll present her work on integrating intermediate outcomes into economic models, a case study in prenatal screening. Amber's work will be discussed by Professor Richard Norman from the Curtin University School of Population Health. So again, Amber, 15 minutes for you to present, and then 10 minutes for Richard's discussion, and then we'll have our final Q&A session of the day. So over to you, Amber.
Thank you. I'll just share my screen. Okay, are you able to see the correct slides?
Yep, that's all good. Thank you.
Yes, I'm Amber, and I'll be presenting on integrating intermediate outcomes into economic models of genetic and genomic testing and using prenatal screening as a case study. So first, I'll just give some general background on genetic and genomic testing and the sorts of outcomes that can be associated with this testing and how this may create challenges for decision making. Next, we'll move on to the methods, which will switch focus to the case study, prenatal screening, where I'll go through how we valued intermediate outcomes using willingness to pay estimates, and then included them in both a cost utility and net marginal benefit analysis. This will lead on to the results, where we'll look at the impact of including these intermediate outcomes on both model findings and potential policy decisions. And then finally, the conclusion, where we find that these can be useful tools, but more research is needed. Okay, so what is genetic and genomic testing? It refers to the analysis of DNA, RNA, or chromosomes, and we're generally looking to identify changes that may influence health, disease risk, or treatment response. Now, the terms genetic and genomic testing are sometimes used interchangeably, but they do have different meanings. So genetic testing refers to more specific and targeted testing, while genomic testing is much broader and can involve large gene panels all the way up to whole genome sequencing, so all of your DNA. Now, because of the complicated nature of genomic and genetic testing, it can result in a wide range of outcomes that extend beyond just quality-adjusted life years. So these can be personal utility, which is the value of knowing from a diagnosis. We can have intermediate outcomes. So this refers to things such as the psychological impacts of receiving a false positive result, false negative result, or inconclusive result. And then we also have process outcomes. So this refers to experience-related factors such as wait times or the inconvenience of procedure. And these can exacerbate the intermediate outcomes. So as these extend the value of health beyond what HTAs are used to considering, it can create challenges for decision making. So I'll just give a brief overview of the current HTA process in Australia. So an assessment starts off with the context, then the clinical evaluation, followed by the economic evaluation. And here we take an extra welfarist approach. So this means we are aiming to maximise health within the health budget. So the goals of HTA are to maximise health, and they have a preference for quality adjusted life years. We then have the budget impact and other relevant considerations. And so the broader outcomes are generally considered in section 5. And it's unclear to what extent they are actually considered within decision making, and there's likely to be inconsistencies across different decisions. And so this study here will focus on section 3, the economic evaluation, and section 5, other relevant considerations. There's also been a recent survey conducted with HTA members across the globe on the use of patient preference information. And one thing that they found was that HTA community members do think that process and intermediate and those broader outcomes are important, but they don't quite understand the impact, and that is one of the key barriers to their consideration. So this has led to a demand to quantify and incorporate these broader outcomes directly into economic models. Okay, now to look at the methods that have been suggested within the literature. So here we have two kind of standard approaches. We have the cost utility analysis using utilities. So here outcomes are captured using utilities. And so within the context of prenatal screening, these studies have tended to derive the utilities from time trade-off and standard gamble methods. And they found only minor decrements in utility, and so minimal impact on model findings. And this did not align with the qualitative literature. So the authors of this study, they hypothesized that one of the reasons for this could be due to the methods used. So they're asking participants to trade process and intermediate outcomes with death. And they suggest that this is potentially not an appropriate comparison. Okay, next we have the cost-benefit analysis and willingness to pay. Now this is the standard approach for taking a societal and welfarist perspective. So we include outcomes beyond health as well. However, there are practical and ethical issues to this approach. So in the context of prenatal screening, for instance, it can be ethically challenging to put a dollar value on the life of a child with Down syndrome. And then next, we have two less standard approaches. So we have the cost utility analysis and willingness to pay. And so here we actually capture outcomes using willingness to pay estimates, which can be derived from discrete choice experiments. Now, the reason this is not standard is because the willingness to pay estimates represent outcomes, but instead of putting them in the outcome side of the ISA, the incremental cost effectiveness ratio, we will instead put them on the cost side of the equation. And then finally, we have the net marginal benefit analysis and willingness to pay. And so this builds off the cost utility analysis framework, but it has an additional step of monetizing quality adjusted life years using a predefined threshold. And sorry, we did not find any practical examples identified in the literature of these two final approaches, although they were suggested. So overall, the literature shows us that the challenges are well defined, but the solutions are underdeveloped. So this brings us to our aims. Firstly, to evaluate how integrating willingness to pay estimates for intermediate outcomes derived from a DCE influences cost effectiveness in economic evaluations. And then using prenatal screening as a case study. And the second aim, to compare the cost effectiveness of two approaches, which we have chosen as a net marginal benefit analysis and cost utility analysis. Okay, to look at the cost utility analysis in a bit more detail. So step A is the analysis without intermediate outcomes. So this represents our standard analysis comparing costs and qualities. Then we have step B, and this is where we include the intermediate outcomes, and the willingness to pay estimates are included in the cost side of the equation. So it represents an increase in the costs. So if we look at this simple decision tree example, you can see that we have the screening test and false positive results. And so within this approach, you would see the willingness to pay entering the cost side as a positive cost. Then we move on to the net marginal benefit analysis. Again, step A is just our standard analysis, costs and benefits in monetary units. Then step B, we include the intermediate outcome, which represents a decrement in the benefit at the relevant stage in the model. So if we again look at this simple decision tree example, you can see a negative outcome is inserted. Moving on to the core components of the economic model. So we have actually taken the economic models from a previous study that we've done. And here I'll just go over some of the brief core components. So we include pregnant women in the first trimester. The intervention is second-line non-invasive prenatal testing for T21 or Down syndrome. And so this is just the more recently introduced type of prenatal screening. And we compare it to the more traditional combined first trimester screening, again for Down syndrome, modelled over the pregnancy duration and using a base case model, which is a microsimulation with 5 health states. Now, because we developed multiple model structures in our previous study, we are also doing a scenario analysis, which is a decision tree with 3 health states. So this just helps us see how intermediate impacts can have a differing effect in a different model. Then the willingness to pay estimates have also been taken from a previous study, which was a discrete choice experiment. And we have included the willingness to pay to avoid a 1% increase in the false positive rate, and the willingness to pay to avoid a 1% increase in the inconclusive rate. And they both just so happen to be 14 Australian dollars. And we also conducted sensitivity analysis around these values. Then with the net marginal benefit analysis, we had that additional step of monetising the quality adjusted life years. And because in Australia there is no known value for QALY, we've used a range of evidence-based values. And these range from $28,000 to $65,000 per QALY gained. Okay, moving on to the results. So here we have the base case model, which is a microsimulation with 5 health states. We have not included intermediate outcomes. And in the cost utility analysis, we find that NIPT is more expensive and less effective. And then we have consistent results with the net marginal benefit analysis, showing a negative net marginal benefit. Then when we add intermediate outcomes, we find that not much has changed. So cost utility analysis, NIPT is still more expensive and less effective. And although the net marginal benefits become more negative, it is still unlikely to impact policy decisions. So now moving on to the scenario analysis, which is a decision tree with 3 health states, we find in the cost utility analysis, there is an ISA of just under $50,000 per QALY. And again, consistent results with the net marginal benefit once we get to 1 QALY equaling $50,000. And so this shows us that NIPT would likely be considered for funding. Then when we include intermediate outcomes, we find that this time things change. So we go from an ISA of under $50,000 to over $130,000 per QALY. So this means NIPT went from being likely considered for funding to being less likely to be considered for funding. And again, we have consistent results with the net marginal benefit analysis. And so the shading in grey here represents where including intermediate outcomes is unlikely to change policy decisions. And the shading in grey shows us that it's disfavouring the funding of NIPT. Okay, so what have we found? Depending on the model structure, the inclusion of intermediate outcomes had varying probable effects, ranging from minimal impact to potentially changing funding decisions. Now, this was a relatively simple testing context where we only test for Down syndrome. And it's likely that as the scale of testing increases, the impacts of intermediate outcomes may also increase. So for instance, there are currently studies looking at expanding non-invasive prenatal testing to being considering over 400 genetic conditions. And here we'd get false positive rates of about 50% for certain conditions. Okay, the conclusions were consistent with both approaches, but in the Australian context, we found that this CUA would be more practical because it only represents a small deviation from current practice and because we don't know the value of equality. Now, although these are potential tools that could be used, each method does raise some theoretical economic considerations. With the cost utility analysis, we are going against the standard principle in economics of keeping the costs and the outcomes separate. Then with the net marginal benefit analysis, we are pretty much just adding in an extra layer of uncertainty to the cost utility analysis. Then both approaches expand value beyond its conventional scope, so it may no longer be in line with the objectives of HTA bodies. Then lastly, is using willingness to pay the correct approach for valuation? I'm still very unsure about this. So our WTP estimates represent individuals' out-of-pocket expenses, while our quality values represents what policymakers are willing to pay on behalf of the public. So here we have a misalignment in the methods. And then I think also very importantly, since I've now moved to England, is how would this work in publicly funded healthcare systems where it's not standard practice to include cost in your DCEs and calculate willingness to pay because they're not used to paying for healthcare. So in conclusion, these methods help us to formalise the consideration of intermediate and process outcomes within health technology assessments, presenting a pragmatic response to the complex challenges. However, concerns still remain regarding the underlying theoretical framework and the methodological choices. So as with most research, we recommend more research. And this is, oh sorry, one more sentence. This is very much an exploratory study, so I'm very interested in hearing people's opinions. Thank you.
Great. Thank you very much, Amber, for that presentation. We'll now move on to the discussion by Professor Richard Norman. Richard, if you'd like to share your screen, and again, any questions, just post them in the chat and we'll come to those after Richard's discussion during the Q&A session. So over to you, Richard.
Fantastic. Thanks so much, Michael. Can you see my slides?
Yeah.
Correctly? Perfect. Yeah, so thank you for the invitation. I think the omics space isn't something I dabble in too much, but the standard of presentation and discussion has been great. So congratulations to all involved, and thank you for inviting me to discuss Amber's paper. So a lot of what I want to say is reiteration of what Amber has already said. I think that the points in black are the points that come directly out of her paper. So I think there is a growing acknowledgement in health economics that a kind of a slavish reliance on quality type metrics is too narrow. And to get a true sense of value, we do need to consider these intermediate and or process outcomes. And I think genetics is probably the best area where this is really, really important. And what Amber's results show quite clearly is that including those intermediate outcomes can matter depending on situation. So even though the choice may not change, anything near the threshold, there's the potential for inclusion of intermediate outcomes to flip the decision reasonably easily. And I thought it was a really nice part of the paper that remained true irrespective of the 3 or 5 state model, which is testing robustness to structural assumptions, which is really nice and not something we do enough. I guess my view is the bit in red here, which Amber's talked about to some degree already. I do think that this broader set of outcomes then are in the quality model is a really valuable potential addition to HTA processes. But there are a number of caveats that I think we and policymakers generally have to be aware of. I think that there are potential unintended consequences in resource allocation if we start introducing financial willingness to pay estimates into models. So we've got to be careful that ability to pay doesn't pollute our estimates of willingness to pay, which I'll talk about. Anything that is standard in a HTA process places additional burden in terms of data collection and data analysis on the system that feeds into HTA. So if we're using clinical trials as the bedrock of HTA submissions, then we're asking more of our trials in terms of collecting information that allows us to populate these additional parts of the model. And I think, echoing something that Amber said, we have to spend a bit of time thinking about what it means regarding the underlying goals of the healthcare system. And I'll talk about that in the context of welfarism versus extra welfarism. So as Amber has presented, this is really the key table. And it strikes me that even though the changes are somewhat modest in some of the analyses between models with and without intermediate outcomes, there's clearly areas where the ISA or the measure of NMB has changed a lot based on whether they're included or not. Obviously, the impact is context specific and depends on the importance of those intermediate outcomes relative to the final outcome. But I took away the message that it can matter, and in many situations it would matter greatly. So this is an important area. Okay, so to tell you something you know already, well, this is Alan Williams, who you may have. I'm senior enough to have heard Alan Williams speak on the Quali model, and the distinction in the literature is between this more welfarist approach, which emphasizes maximizing utility, and extra welfarism, which emphasizes maximizing health. At least the way it's implemented in HTA, that's what we're doing. I think, as an aside, there is a bit of a nomenclature issue here in that extra welfarism suggests that it's welfarism plus something, when actually it's a completely alternative framework for making decisions. We're no longer maximizing utility, rather we're maximizing health. And that's a decision that we as a field or policymakers whom we're trying to influence have made. And it's something which I think is dominant in most industrialized countries. The issue I want to raise here is that combining of QALYs and DCE derived willingness to pay, or any willingness to pay estimates, leaves us somewhere between the two frameworks. So the question is then, what are we actually maximizing? I think you can fudge it a bit and say what we're maximizing is social welfare, which can be measured both through QALYs and through willingness to pay. I don't know if that is strictly reasonable. It just becomes a lot hazier to me what the actual decision rule is here when we have models which include those very different kinds of data. I'm not saying it's wrong, and clearly the QALY model itself is a convenient metric. So is this just an additional convenient metric? I'm not sure, potentially. Okay, I wanted to talk a little bit about the QALY framework in HTA. So in Australia, I sit on the Pharmaceutical Benefits Advisory Committee, and I don't know what the comparable body in the UK is for comparison, but clearly, first I want to say that the QALY model itself is extremely highly valued by both clinicians and economists in that area, because it allows that comparison between conditions, as you're all very familiar with, and it can be estimated with very little additional data. So asking for EQ5D or SF36 converted into the SF6D is a very easy thing to ask trialists and pharmaceutical companies to provide for us to help us make better decisions. But again, of course, there's an acceptance that it is narrow and it fails to capture complexity, which is very true in this omics space. I do think that there is a distinction here to be made between the base case model that HTA agencies request, be it NICE or the Canadian, whatever CADIT is called now, or the PBAC, and the things that they value. I think that my experience is that in Australia and presumably elsewhere, HTA absolutely does consider a whole range of things which are not well captured in the quality framework. The question isn't whether those things matter. The question is whether we should put in place a formal framework where it's integrated into the same metric, or whether we just present cost per quality alongside all of those other considerations and proceed and allow the committee to informally weigh up the two things, which is the point I was trying to get to with the meme on the right hand side. Okay, a couple of issues with intermediate outcomes. I think that there is the potential for intermediate outcomes to lead to double counting. And it's difficult because it's context specific and it's certainly not complete universal. So for instance, reassurance and certainty are often flagged as intermediate outcomes which are not well captured by the quality framework. But to some degree they are, because those things flow through into mental health, which then do contribute to utility weights. Similarly, convenience is flagged as an intermediate outcome, and that convenience isn't in the quality model, but it can potentially flow into medication adherence and therefore better survival, which is in the quality model. So I think the binary of intermediate outcomes and final outcomes is okay, but we've got to be careful that the intermediate outcomes don't bleed into the final outcomes. I also think that if we are going to be introducing DCE-derived willingness to pay into our models, we have to make sure that willingness to pay is independent of ability to pay. And there's obviously a huge literature about how we do that. If we are talking about personal willingness to pay for screening or for therapy, we could potentially talk about theoretical trade-offs with a fixed budget constraint rather than answering on behalf of themselves. Or we could talk about normalizing willingness to pay by income and then reporting it as a percentage of income instead, which are just two ways of getting around that ability to pay problem. Okay, so Amber raised a couple of key questions in the paper, and I've just jotted down some quick responses before I conclude. I think that the use of individual willingness to pay values based on out-of-pocket expenditure is difficult because willingness to pay can be highly correlated with the ability to pay, as I talked about. And I don't think we do have this common framework yet for studies that include intermediate outcomes measured through willingness to pay and quality values, which are estimated more externally with value sets and self-report of health states. And I absolutely agree with the point Amber made towards the end of her presentation around the applicability of these methods in publicly funded health systems. It's very hard in stated preference surveys to mitigate protest votes or confusion votes because payment for healthcare is a difficult thing to imagine. I think you can think about reframing stated preference surveys, not in terms of individual payment, but in terms of societal payment. So things like changes in taxation or special levies, kind of theoretical levies to pay for new services are ways of getting around that, but none of them are perfect, and all of them add a layer of complexity and potential misinterpretation that we have to be concerned with. So just to summarize, I think this is a really great paper, and I look forward to seeing it fully in print. I think the addition of intermediate outcomes into economic evaluation is really important and is something that a lot of people are working on for good reason. But there is a tension between the things that count for decision makers and what we should formally count as part of an ISA in an HTA process. So some things matter, but should be left as contextual factors, and the committee system itself should adapt to considering them in parallel rather than focusing solely on the cost per quality. And I do think also that we need to take a step back and think about what that theoretical framework is when we start combining data in the way that has been proposed, both in Amber's paper and in papers across the literature. What are we actually maximizing? And to me, that's still a question that has to be answered. So that's everything. Thanks so much for the opportunity to present. Keen to hear discussion.
Thanks very much, Richard, for the discussion. While people are having a think of some questions to pop in the chat, Amber, is there any responses to Richard's discussion that you'd like to highlight just now?
Yes, firstly, just to say thank you for reading the very long draft paper and for providing your comments. It's given me lots to think about. I definitely agree with pretty much all of your points, and that it is getting rid of one of the main benefits of equality, that's allowing the comparison, because the willingness to pay estimates are now context specific and dependent on the attributes that have included. And I also do think it is sort of a convenient measure. And I guess I was just trying to think about how we can respond to this rapidly changing genomic testing. I did think that potentially, like you said, intermediate outcomes and process outcomes are considered in section 5. They're just not quantified and formalized. And I did think that actually one benefit to formalizing it, which I think you might have thought as a negative, is forcing the data collection. So I thought that if it's forced in section 3, then actually people will have to do these studies, like pharmaceutical companies, instead of just sticking to the economic evaluation, they might now have to do a DCE alongside. So I think that was the only thing that I thought potentially slightly different in terms of your views. And then I completely agree with the issues on ability to pay. And I thought an interesting way of framing the DCE within the UK context. But thank you. I think this will really help my discussion.
Great. Thank you, Amber. There's just a question in the chat now related to Richard's comment about the potential for intermediate outcomes to influence end outcomes. Do you have any reflections on the time horizon we should be using when measuring QALYs in this context?
So within the context of prenatal screening, I chose to model just pregnancy duration purely for a simplification. I feel like my get out of jail free card was that this is just a case study and I'm not actually looking at the cost effectiveness of NIPT. And the reason I didn't extend the time horizon was because things start to get complicated as termination is a choice. So then the addition of life years just sort of complicates things. And then most models that I identified in the review did just use pregnancy duration, including the MSAC PSD. But again, I think that there's definitely potential to expand these models. And then also one thing that I thought about was including time components. And this is where the wait times could then also be incorporated. And one other thing that I didn't mention is the DCE actually looks at metro versus rural. And so I think this is an important difference that should be captured in the model, which isn't currently. And this is where wait times could be important, and also the differing impacts of intermediate outcomes and how this can affect having different policies and sort of lines of intervention for these communities. So sorry, that was not a proper answer.
Great, thank you. Yeah, definitely covered a lot of ground in this presentation and discussion and raised a lot of interesting sort of theoretical and normative questions. Just one more question from me is, given that you're sort of valuing genomic testing in monetary terms with willingness to pay, another question that I think is relevant, especially in publicly funded healthcare systems, is who should we be asking to value the test? Should it be the patients or people receiving the intervention, or the general public, or payers? What's your thoughts on the sample that we ask to complete these DCE surveys?
Well, I think that is a great question. And so overall, I feel like this paper actually does have 2 questions to it, although I only answer one. So the first is whose preferences do we use? The second, what factors? And so I've only focused on section 2, but for the discrete choice experiment, I actually chose to not use the general population, not use a patient population, and I use something in the middle. So I use people who are interested in pregnancy, and that was purely to try and compromise between both of those. So as we know, we use general population because taxpayers' money that is funding the health system, and then patient population because they have a greater understanding. So I wanted to get a compromise between the two, although in hindsight, if I were to go back, because of the decision-making context that I'm using, I would use the general population. That being said, I do think specifically in genetic genomic testing, because it's so complicated, actually the use of patient preferences plays a greater importance than in other health fields.
Yep, definitely. Thank you.
Thank you.
Okay, I don't see any other questions in the chat just now. Oh, Francisco's got his hand up. Do you want to unmute and ask a question,
Yeah,
Francisco?
because I wish Amber was before me, so because then that question that you asked me, Michael, would have been easier to respond. But Amber, yeah, I did want to ask you about this, like in the absence of those that quality data, how do you think we can then convince policymakers that that something is valuable if we only have patient preferences, or would that not be enough then?
Oh, sorry, I just missed a word that you said. In the absence of what?
Of quality outcomes.
Yes. Oh, so if we don't have qualies, then how can we show the results?
If using like willingness to pay from patients.
Oh, okay. So, I mean, like we said, qualies is the preference, but I don't actually always think they are the best use. So even in this case where I do the cost utility analysis, again, it's a case study and I've used the utility values that I found in the literature, but I actually don't think they're that reliable, just based on face value and also looking at the methods. So I think not the problem, but they prefer qualies, but again, they're not generally available and people are doing cost effectiveness. So yeah, but I don't think there will be a change anytime soon for the preference to be cost benefit analysis or willingness to pay. So I think because of all the issues that there are with willingness to pay and ability to pay. Yeah, so I'm not sure if that really answers your question.
You did, yeah.
Oh,
Great. Okay. I think that's all the questions for that presentation. So I'll just share my screen again quickly. This one. Can everyone see that okay? Not yet. Yeah, good. Okay. So yeah, that brings us to the end of our 3 presentations and discussions for today's ECR webinar. So just before we wrap up, I'd like to firstly thank all of our ECR presenters. So thank you to Martin, Francisco, and Amber for their excellent presentations. Really looking forward to seeing the papers and PhDs all completed and published, and hopefully all the feedback today was useful. I'd also like to thank our 3 discussants, Professor Nyem, Professor Downs, and Professor Norman, for their time in preparing their discussions for the 3 presentations, and particular thanks to all of our participants in Australia for joining the webinar on a Tuesday evening. So this slide here is just the overall aims of the Economics of Genomics and Precision Medicine group. So including connecting researchers, generating ideas, enabling collaboration, supporting ECRs, and trying to build a global network of health economists. And hopefully in today's ECR webinar, we've hit most or maybe all of those objectives. It was really great to hear about a wide range of ECR projects at the intersection of economics and genomics. So hopefully you've had some useful feedback. I think the discussion has all been great. And before we finish, I'd just like to acknowledge all of our SIG conveners. Particular thanks to Tian Zhao, our other ECR convener, and to Sally and Lizzie for helping to organise and coordinate the webinar. But thanks to all of the SIG conveners who do a great job in organising these events. And final slide before we close, I'd just also like to note that the Economics of Genomics and Precision Medicine Special Interest Group post regularly on LinkedIn and Blue Sky accounts. The links are here if you'd like to give us a follow on social media. Also, feel free to share these pages with any colleagues that you think might be interested in economics and genomics or precision medicine. So thank you very much, everyone. We hope you enjoyed today's webinar. Thanks again to all our presenters and discussants, and hope you enjoy the rest of your morning, afternoon, or evening, wherever you are, and hopefully see you all again soon. And yeah, stay tuned for news of any future economic SIG activities and webinars throughout 2025 and beyond. So thanks very much.
Thank you.
Thank you.
Thank you.